So one of the things on chapter 8, the nervous system development chapter, some of the learning objectives that I have in the PowerPoint, I sort of, like I always say, you can't put everything on the test. And some of the things I've sort of backed off of when I was writing this last test, which I just finished it this weekend, um, which is what made me do that learning objective review thing. But the you're going to have more of this in neuro rehab. You're going to have more. So CP, sure, it's interesting, and you'll work with patients who have CP, but you're going to have more of that in neuro rehab. And so, knowing that it's a non-progressive disorder, that's important. We should know that it's not getting worse. Um, but also that a lot of the motor disorders and things that you have to do with what area of the brain is involved. However, that information did not make the test. So I'm not going to ask you to study that between now and the next test. And the other thing too is there was a short amount of time between the last test and the next test just because of competition for resources, basically, when I can get um, reserve the room for the computers and all that stuff. So I would like to have more time between this test and the next test, but we have what we have. And so I can't put everything on the test. So the signs and symptoms of CP, don't put that on your cheat sheet and it's not going to be on the test. For the autonomic nervous system, the main thing I want you to know is just the primary functions of the sympathetic and parasympathetic nervous system. So there's all that great information in the book about receptors and the different types of receptors, and I'm not going to ask you about that. So even though it's lovely information, I'm not going to ask you about that. So really just the effects of parasympathetic versus sympathetic nervous system on the different organ systems of the body, because that's what the autonomic nervous system is really trying to do, is regulate your viscera. Um, so the sympathetic nervous system, it's trying to optimize your blood flow so you're ready for action. So it's not it so it controls those precapillary sphincters that close off the capillary beds that you don't need for your core body. So your hands might get cold if you're in a sympathetic stimulation state. And it speeds up the heart and it increases the contractility of the heart. And it dilates the pupils so you can take in more of your surroundings. So it releases norepinephrine, and that makes you focus more on the detail in your surroundings. And that's like a fight or flight thing, which is really important. And then the parasympathetic nervous system has sort of opposite effects, although not all of them are entirely opposite, but it constricts the pupils because you're like, okay, we're safe. We can digest our food and we can slow the heart down and we can send blood to our extremities and warm them up a little bit. So my right hand's always colder than my left when I've been working on the computer all day because just not a sympathetic response, but I have my right hand using the mouse and it's always colder than left. So so with the that's what I want you to get from the autonomic nervous system is what are the opposing responses. So hopefully that makes sense. So take a little bit of time looking at that chart in the book that says, like the sympathetic increases the heart rate and the parasympathetic decreases the heart rate. And those things, the effects on the organs, and then just its general overall function. The When you talk about spinal cord injuries in neuro rehab, you'll talk about autonomic dysreflexia and other autonomic. We'll like briefly mention it towards the end of the quarter in this class, but you'll talk more about it. And that's you get autonomic dysfunction because you've got interruption in the system, basically. So, and then sometimes you'll get autonomic dysfunction with different circulation issues because you've got interruptions in the system. So, that's kind of what I want you to get. And like, could you look at somebody and see if they were having a sympathetic response? Are their pupils dilated? Are they anxious? Are their hands cold? All that good stuff. And if their hands are cold, maybe you can't get a good reading on a pulse oximeter for O2 sats. They're having sympathetic response. So it all does make sense clinically, but the detail in the detail in our textbook is extreme. And we don't need to get to that level, especially for certain chapters like the autonomic nervous system chapter. We're just like barely touching a little bit of it. And chapter 25, the cerebrospinal fluid chapter, also barely touching any of that. So basically just what the CSF does, it cushions the brain and gives it the right electrolytes and proteins. It filters blood and creates the CSF. It's unidirectional flow. It starts in the ventricles and it goes back and then dumps into the venous system, just like the blood circulation dumps back into the venous system. So,
Just
and
really
that's,
basic. Oh, I'm sorry.
go ahead.
Oh, I was like, so basically with chapter 25, it's just the basic functions of the CFF system.
Exactly. Basic
Okay.
functions, and then a few of the pathologies, like knowing the difference between an epidural and a subdural hematoma. So the layers of the meninges. And it kind of makes sense that epidural is above the dura and subdural is below the dura. And one of the epidural and subdural hematomas have similar symptoms, worsening headache, decreasing level of consciousness, that sort of thing. But epidural happens faster because it's arterial bleeding, and subdural happens more slowly because it's venous bleeding. So, knowing so somebody might have a venous bleed that's happening between the dura and the arachnoid of the meninges, so subdural, and they might not have symptoms for days, and then all of a sudden they lose consciousness, seemingly all of a sudden, but it's actually that slowly bleeding into the space. And then the epidural hematoma between the dura and the skull, that puts pressure on the brain a lot quicker. And it's also arterial bleeding, which arterial bleeding is a lot more forceful and quicker. And so the symptoms come on more quickly. So I always think epidural hematoma, I always think skier versus tree. That's the classic. So it's usually trauma. It's usually pretty major trauma. And a lot of time in skier versus tree accidents, the person walks off the slopes and then collapses later once the bleeding gets enough that it's putting pressure on their brain. And then hydrocephalus is just a blockage in the unidirectional CSF flow, and it can be congenital. You can be born with it. So it's a defect that happens during development. Or it can develop later on for various reasons. And usually so why, here, let me ask you a question. Why would you see symptoms in a child that you wouldn't see in an adult, like an enlarged head? So with adults who have hydrocephalus, they don't usually have that enlarged head. Why do you think that would be?
To it.
Say again?
They grew into it. I mean, I would think as a smaller child, and also they're still growing and developing.
Right. Well, and kids' heads are big in proportion to their bodies, but
Right.
what else is unique about an infant's skull that doesn't occur in an adult skull?
The suture lines, right? Because the head is
Yeah.
the skull's still soft.
It's the suture lines are still soft, the skull's still
Yeah.
flexible, so the additional fluid expands their skull. An adult, the suture lines are firm and it doesn't expand their skull, just makes pressure on their brain. So you tend to see more cognitive and neurological effects in adults. and you see the large head and the poor feeding and the downward gaze with children with hydrocephalus. So that's kind of the main thing with that. And the way they treat it is with a shunt. They shunt the fluid um, away from where the clog is, where the obstruction is. So that's good. What was the other thing that you asked me, Tricia? I have to look. Look at what that other thing was. So we had about this the CP and the receptors in the autonomic nervous system. Oh, and the functions of basic functions of subcortical white matter. Really the basic it's communication. It's axons, and it's just myelinated axons that are um lines of communication from one area of the brain to another. So, I mean, that's really all you have to know about subcortical white matter. There are all the different types and all the different fibers and everything. That's fine. You don't need to know that. Or, just know like, hey, it's complicated. Let's move on. Let's move on to the next subject. And the next subject is complicated and interesting too, which is the cerebrum stuff. So hopefully that's helpful with a lot of the chapters in the book where they go into a lot of detail like that. It's more of an awareness thing. Like I want you to be aware that that exists and like basic functions. And the same thing. So talking about the diencephalon, anything with the word thalamus in it is part of the diencephalon. And knowing just the basic function of each area, um, that's really what you need to know. So like the thalamus is like a relay station. And is anybody old enough to have seen the movie Osmosis Jones? It's from yeah, it was from like just me and Darren maybe. And I saw it when I was,
Thanks, guys.
an older adult. But it was they had like actors with a storyline going, and then they went into like an animated inside the body thing. So all of the parts of the body were the characters in what was going on with this person. And the the thalamus was like the executive assistant for the brain. It was taking all the incoming messages and deciding what needed to be passed on and what could be dealt with without bothering the brain. So really kind of that's what the thalamus does. It receives all the sensory information, it processes it, and sends some of it to the cerebral cortex, and some of it doesn't. So a lot of processing goes on in the thalamus. But in order to be consciously aware of stimuli, it has to go through the thalamus. So the brain's never going to find out about it if the thalamus doesn't let it know. So a lot of when we start talking about vertical systems, a lot of our sensory systems going up to the cerebral cortex, all the conscious ones go through the thalamus. And we have a neuron that goes from the periphery to the spinal cord, and then one that goes from the spinal cord to the thalamus, and then one that goes from the thalamus to the cerebral cortex. So it's a 3 neuron pathway. And at any point, so the spinal cord can say, nope, I'm not going to send that up. Or the thalamus could say, nope, I'm not going to send that up. So any place in the chain, the information can stop before it actually gets to where you're going to process it and figure out what it is. So I think that's kind of interesting because it used to be thought that the nervous system was like an electrical circuit where, you flip the switch and the light goes on. But it's really like you flip the switch and then it goes over here, and then somebody else decides that they're going to flip their switch, and then it goes to the next one, and then that person decides that they're going to flip their switch before the light actually comes on. So it's a 3 neuron pathway, which is kind of interesting. So, so the first part of chapter 27 is about the diencephalon. It has all the detailed anatomical information, which we're not even going to talk about, and all the different nuclei of the thalamus and all that we're going to talk about. So just know that the thalamus is conveying information to the cerebral cortex, all the sensory information that comes in. It's a relay station, basically. And it's what anything that's going to be conscious is going to go through the thalamus. Some sensory information that's actually conscious, the only sensory information that's actually conscious that doesn't go through the thalamus is the olfactory nerve, the smell. The smell goes straight to your brain. Isn't that interesting? I don't know why. I mean, there's no why about it. It just is. But I just think that's pretty interesting. Kind of like you smell a familiar smell and like a pie baking or something, you say, wow, that's just like my grandma's house. It goes right to your memories. So the smells are interesting. But then for the cerebral cortex, then has anybody got to the cerebral cortex yet? No, I didn't
No.
think so. I didn't think so. But really, with that, I just really want to talk about localized function and dysfunction. Like, what's this area supposed to do, and what happens when it doesn't? And so, that's the main thing. And so, in the learning objectives review that I posted in that PowerPoint, there's a chart that is localized functions of the cerebral cortex and disorders. And for disorders, there are a lot of nice mnemonics for the nervous system, and one of them is the 4 A's of cerebral dysfunction, which is agnosia, astereognosis, and those are the sensory ones, and then apraxia, which is losing the ability to do skilled movements, and aphasia, which is language disorders. And language disorders, besides it just being one of the 4 A's, aren't on specific language disorders aren't on the next test, but they will be on the test after that. And we'll talk more detail about the specific language disorders. And then the different types of strokes, the different arteries and what they affect. And they all kind of make sense, I think. And I put a little chart in the PowerPoint about that too. Because like the anterior artery takes care of the frontal lobe, and that's where your executive function and your personality is. So if you have an anterior artery stroke, you get a lot of the other stroke symptoms, but you also get personality changes. When it's the posterior, it takes care of the occipital lobe, and so you get vision issues. And when it's the middle cerebral artery, that's where you get language difficulties and all the stroke symptoms we think of as being normal stroke symptoms. Um, and when it's the vertebral or basilar, you get cranial nerve and coordination issues because it affects the cerebellum. And then sometimes vestibular issues too. But the so it's just knowing like that each area of the blood supply supplies a different part of the brain, and what sort of the cardinal symptom that would mark it out as saying, you know what, that's got to be a posterior cerebral artery stroke because you have the cortical blindness, or it's got to be anterior because you have the personality changes, or it's middle cerebral artery because you have language problems. So just knowing the different, there are like 4 different ones: middle, posterior, anterior, and vertebral basilar. And just knowing what the cardinal symptom is for each one. So if I said, oh, you are working with someone who had a stroke that resulted in these symptoms, you would probably be able to identify that that's what. And 60% of strokes, ischemic strokes, are middle cerebral artery strokes. And so that's why we think of those as being the typical stroke symptoms. And you'll see that that's a diagnosis that you'll see a lot is middle cerebral artery stroke. That's an ICD-10 code or something. So you'll see that a lot because a lot of people have that. What else? Oh, transient ischemic attack. You should know what that is. So a transient ischemic attack is like angina for the brain. You have a partially blocked cerebral artery, like angina is a partially blocked coronary artery. And so you have symptoms for a short time and then they go away. And so with a transient ischemic attack, you have neurological symptoms and then they resolve within 24 hours. And with angina, you have chest pain and it resolves usually with rest or medication. And then a fully occluded artery is a heart attack or an MI or a brain attack, a CVA. And that's where you actually have tissue death and you have ongoing symptoms. So just knowing what a TIA is, and the T is transient, so that kind of gives you a little bit of a clue too, on that. And what else? Any questions that you're thinking of?
I have a question about the Physio U assignment.
Yes.
It says we're supposed to do
Oh, I
parts of the
know it.
brain, but we
Yeah.
already did it.
Oh,
Is there a
that's good. Do
different
it
one,
again just for
or
fun. Do it again just for fun.
is there a different Physio U assignment, or is that one
I don't
just
think there
being
is,
taken
but
off?
I'll check just to make sure,
Okay.
and I will
Thanks,
let you
Cody.
know.
I was wondering the same thing. I'm like, what physio
You're
use
like,
assignment? There's
this
nothing on
looks
here.
familiar.
Yeah.
Yeah, maybe just you could review it. There's one that has uh, things about cerebral spinal fluid and the ventricles. And that's what it should. It was that on the parts of the brain one?
Yes.
Okay, well, there you go.
So
They
just
are they
do
are the
that one
same.
again.
Well, if you want to, I'm not going to make you, but if you want to, you can. And I don't think I had it for points in the module. Let me look. I just put it as a reference. That's funny. We were just talking about Physio U at the staff meeting, and I was saying that there's a ton of stuff in there. Like you have access to all the information in there, not just stuff in assignments. And so it's actually a really good reference to study for different things. Or if you want to see a video of a particular gait pattern or something like that, there's a lot of videos on PhysioU.
TikTok.
And also for like treatment techniques, when you're doing the neuro rehab next quarter, some of the different treatment techniques, there are videos on there, and they're gait analysis videos. So those are all available to you with your membership. So just because we don't assign them doesn't mean they're not useful to you. And they just added a bunch of new PTA content, which I need to go in and look at. But
I gotta ask you guys, have any of you been watching people when they use an assistive device around you now? And you just
Literally, the very
All
next
the
day in
time.
my
locked
clinic,
in
there was
on
a
it?
cane and there was a walker. I was so locked in at their feet.
occupational hazard.
Oh my goodness. I tell you what, I was watching it recently and I'm like, they have a hip hike. What? I'm like, look, they have a hip hike. And I saw it right away. They're like, oh, yeah, good catch. I didn't notice that. I'm like,
Yeah,
but
that's
I
so
do know
cool when you start to see that stuff.
it. I just chuckled because and now I'm like, oh, that's a 3 point. Like, I don't know. I laugh now because I focus more when I see somebody with an assistive device or if their gait pattern seems off, I try and figure out like what are they doing that
Yes,
makes it look
yes. And
slightly off.
that stuff you can write in your objective data. You can say they walk with a step two gait or a step through gait or a 3 point gait or whatever they're doing. So that's good stuff.
Or they drag their cane behind them.
You're
No,
supposed to
Saw
no,
drag
saw a
sir.
the
lot of that today.
That's not how that works.
Yeah.
One of our patients had a front wheel walker and they put little skis on the backside.
Mhm.
Where it's supposed to
Sure,
be like
yeah, you see
stabilized.
those little silicone attachments. Yeah, and those are for like just gliding around. Those are good. And better than tennis balls because tennis balls wear out.
Did see a gentleman today had the assisted device on the same side as the affected leg, and wasn't our patient. Wasn't I really
Right,
wanted
you
to
can't just
correct it,
butt
but I'm
into
like,
somebody's life.
and I'm like, nope. Somebody else is going to tell this to this person. It's not going to be me.
Well, that's it. You see it, but when they're out of your jurisdiction, you can't really
Yeah,
do anything,
exactly.
unfortunately. But yeah, you see that all the time. Or the classic one that I always see out in public is people are using like a wide base quad cane. Completely wrong. They're not even putting it all the way down. They're like up on two legs, and you just gotta turn away. If it's your patient, then you can correct them. But if it's just somebody out on the street, or the other thing that I see is people whose assistive devices are at the wrong height for them, and I'm like, ooh, wish I could fix that, but I can't until you walk into the clinic, and then that'll be the first thing I do.
Hmm.
But sometimes you'll see this a lot with people who use a lot of times with four-wheeled walkers, people they lean on the walker. They bend, it's too low for them to start with, and then they lean way over. And sometimes, I mean, sometimes they do it for various reasons, but if you try to get them to stand up straight when they're doing it, it's not always easy to get people to change their habits. Or the classic thing too is they push the walker forward with their arms and their feet stay in the same place. That's a ticket to the floor. I don't like that one.
We have a patient who refuses to ever lock her four-wheeled walker,
Yeah.
and I call her out on it all the time. And she still refuses to do it.
Think it's going to get
Well,
squirrely on her one day.
That's the
it
reason she's in here.
yeah, it could even get squirreled. I had this one, he was the nicest man. He was so unstable. I hated sending him out the door because I was afraid, like a lot of times I'd walk him out to his car because I was afraid he's gonna fall in the parking lot. He just scared the crap out of me. Um, and I wanted him to use a more supportive assistive device, but he didn't want to. He wanted to stick with the cane. Oh, he needed way more than a cane. But you can suggest, recommend, and whatever, but people are adults, they can make their own decisions. And they can decline to follow your recommendations, despite the fact that you're terrified that they're going to fall. So, yeah, unfortunately, I've had a lot of those people where I was terrified that they were going to fall. And I have walked many a person out to the parking lot because I was afraid to send them out. But oh well, what are you going to do? One time, my husband and I were eating out and we were seated right by a window, and there was a guy that looked very unsteady getting into the driver's side of the car. And my husband said to me, do you think that guy should be driving? I'm like, it's none of my business. Just stay away from him on the road.
We're gonna stay here and get dessert. Come on.
Yeah, yeah, really. Why do you have to go?
Yeah.
We can wait.
Yeah.
But yeah, so yeah, you can help people when they come to you, but you can't just randomly. That's the same thing like you'll see people you're in the gym and you see people using bad form or doing things that they're going to hurt themselves, and you just got to let them because they're not your responsibility, or you're not their mother.
Just
That's more
Whatever.
billing for us, guys.
There's this CrossFit gym that's just down the street over here, and sometimes I walk by, I want to start handing out business cards. I'm just like,
Yeah.
you're gonna hurt
Come see me
yourself.
later. Come see me later.
Yeah. Like, I know a guy, you should go see him. But yeah, you can, no matter how much you know, you can't, sometimes you can't tell people. And that's what with a lot of the neuro knowledge, we can't make diagnosis and stuff, but because I worked with so many people with Parkinson's, I can just look at people and tell they have Parkinson's or just watch them for a little while. I could see people on TV and see that they have Parkinson's. And but you can't tell people that. They can tell you that they've been diagnosed with Parkinson's, but you can't tell them that you think they have Parkinson's. So it's a little bit sometimes it's frustrating as long as you remember your scope of practice and your mission and everything. It's okay, but sometimes it can be frustrating.
Oh, kind of on the same page. I I don't think anybody else is having this issue, but with our project for interviewing somebody with,
Yes.
so I probably would have been done by now, but I had to cut through some red tape with our facility because I'm talking to a patient. They gave me the
Mhm.
okay. However, I think me being part of their treatment turned into I don't want to violate any HIPAA or any sort of anything along the lines of that. Have you guys had issues with this before where a student was like, well, I've got somebody, but I need,
Yes.
some additional release forms?
We do have a release
Okay.
form if your facility or the patient needs it. I can get you a release form. The
Okay.
other thing is, I would say for all of them, whether it's, and that has come up before, where it's a patient in a facility where you are working,
Mhm.
because then there are issues.
Right.
But feel free to change names and details,
Perfect. Okay.
um, because you can't, because that is protected private information.
Right. Right. I mean,
And a lot of people too, even if they're just interviewing a friend, they change names and they leave in the pathology details, but leave out
mhm.
the personal details.
Okay. That was going to be my other question. I think, I was planning on just changing their names. Their story is very public in our community. It was
Mm-hmm.
in the news, but again, that's different because I am part of their rehab team. Is I think makes it a little bit more difficult for me. So,
It
yeah,
does.
if I
And
could,
and I certainly don't require you or expect you to divulge any personal details.
okay,
Um, and and most people when they're writing their paper, and that I'm glad you brought that up because I'll post an announcement about that. Most people do leave out people's names or they'll say, well, I'm going to call this person John or whatever, you can use a pseudonym. You don't have to use their name. And in fact, it'd probably be better if you didn't in terms of just personal privacy.
right, right,
Um, and so, yeah, and we have had that come up before, and it was exactly the same situation where the student worked in the facility where the person was being treated. And so there are issues with that, but
okay.
I do have a release form if you need one.
Oh, I would love one. My medical records department, they kind of said we don't see an issue, but there's like this really weird gray area. The manager drafted up a document, but I think it'd be safe also to have one on hand for the hospital, on hand from the
Yes.
school, so that way you know, it's very clear that, I have permission from, the patient and clearance on both ends. So,
Absolutely, yes. And that has come up before. So we do
okay.
have a non-disclosure form or a release form.
Okay.
So I'll
Yeah,
get
I,
that
I
to
would love
you.
one just to keep my bases covered that I'm not
Hmm.
doing something.
Absolutely, because
Okay.
that is important. And um that's exactly the situation that's come up before where the student
Okay.
worked in the facility where the person was being treated.
Perfect.
And it is different when you're part of the patient's treatment team. And then we'll talk about this in ethics next quarter, but there's also like issues can come up when either you're treating people that you know, and when you live in a small town, that could easily happen. Um, the and like I treated someone that I had worked with many years ago. And so we worked closely together. We knew each other really well. I knew her family, she knew my family, that kind of thing. But then later on, we hadn't worked together for a long time. And she came in with a patient in the clinic. And then she said, "Oh, well, don't be a stranger. Give me a call. Let's go out for coffee or something." And you really can't.
Yeah.
For, there's time limits and that sort of thing. And just like within the scope of your licensure, you can't have personal relationships with. And some of the therapists that I've worked with, somebody got on their schedule that it was someone they knew, and they probably, when they scheduled, they probably asked for that therapist, and they just felt it was a sensitive issue, so they transferred them to another therapist, and that's reasonable. But you do have to be careful, and when you live in a small town, like you said, the person's details are known and all that other stuff. It's a gray area there. It's a little bit weird because you don't want to disclose any information about your patients. When I was in one of my full-time clinicals when I was in school was at Swedish Hospital in Seattle, and there was somebody in the hospital, and I just heard this through staff meetings and stuff, but there was somebody in the hospital who was a very well-known local celebrity. It was like a local newscaster or something like that. I didn't know the person because I didn't live in that area, but it was somebody that, like, you see every night on the news kind of guy, was in the hospital. Well, they had to tell everybody in staff meetings, like, you can't talk about this. You can't say that, "Oh, Bob Smith, the guy from Channel 6, he's in the hospital." You can't do that.
Yeah.
So they had to remind everyone, like, this is protected information. The fact that he's in the hospital isn't our information to divulge. So it was interesting, but that was a good lesson for me. And I've definitely taken care of people in the hospital who were like locally well known, and I just don't say anything to anybody. Like, you can't even go home to your family and say, "Hey, guess who's in the hospital?" You just can't do that. So much as you might want to, but you can't.
Yeah. Okay.
So interesting stuff. So, I don't know, how's everybody feeling about the pace of information in the class and
I don't know.
everything?
I feel like oddly confident, but at the same time, like I don't know everything. And
And you never will.
yeah, and my
I don't know
PTs
everything.
joke with me. They say, like, just learn what you need to learn right now and move forward. It's like a lot of the stuff you're learning now. They said, don't even ask me to bring it up because I don't remember what you're learning right now. So
Right. Well, Carrie had a really good Carrie Van Loo, the lab instructor up here in Whatcom, and you'll have her for some of your clinical contact and stuff. But she said basically for entry level, we have to teach people not to hurt patients. That you just have to know enough not to hurt people. And then you will develop your skills as you learn, in the clinic. And it's true. You know just enough. I mean, entry level is entry level. You don't know everything, and you never will. Even when one thing that really stood out to me about 10 years after I was out of school, I had been in the clinic for 10 years, and I had been working with people who had strokes for a lot of that time. And the teacher who used to teach the neuro rehab class before Misty, asked me if I would sub a lab weekend for her, and it was the stroke lab weekend. And it was great. We had so much fun. And I got one of my patients to come in and talk to the group and answer questions and everything. And we did all the whatever. And before the lab weekend, I read the chapter in their textbook because it was a different edition. It was the same textbook, but different editions from what I'd had. And when I read the chapter, and the first thing I thought when I read it is like, oh, this is gold. This information is great. But then my second thought immediately upon the heels of that was I wouldn't have understood this when I was in school at all. But to me, having had then years of experience working with that patient population, it was great information. But as a student, I don't think I would have understood it. So you're not going to know everything, and we certainly don't expect you to know everything. But we were talking about actually at the staff meeting strategies for getting you ready for the board exam. That's our job, is we got to get you ready for the board exam and make sure that you know enough not to hurt people. And so I mean that's really our goal. We want to teach you enough so that you can pass that board exam and get licensed. So then you can go out and get the clinical experience and help people.
Are there some resources that we could that you can direct us to for practicing for the board exam?
Absolutely. So one of the things that that you get as part of your student fees and everything is you get 2 practice exams from the FSBPT that are they're called the PEAT exam. One of them is a retired exam, like it's one that they used to use, but now they retired it. And the other one is a practice exam. And we'll suggest to you a timeline. One of them we're going to take together next fall, before when you're finishing up your academic portion. We'll take one together, and then we'll suggest timelines for taking the other ones. And so the another source, there's a publication that's called Score Builders, and they have score builders for the NPT, the PTA NPTE, and the PT NPTE, National PT exam. And there are 3 practice exams in the Score Builders that come when you buy a Score Builders package. There are 3 exams that come with that. And there's another resource that I think now is a good time to start using it. It's called PTA 365. Are you using it, Mason?
Yep, I got it right here.
Yep. So PTA 365 is it's free, right? Is it still free?
Was for me. I downloaded it about 6 months ago.
Yeah, so it's free, and it gives you a question every day. And so now you're starting to learn assistive devices and gait and all the other things. So earlier on, it would have been too early, and like half the questions you're going to go, what the hell? Yeah, you're at that point right now. But the nice thing was, so some people just answer that question every day. And some people like wait 7 days and then do like a little mini quiz at the end of the week, or however you want to use it. But that one's free, and that's pretty handy little thing to help quiz yourself and get used to the types of questions you're going to see. There's another thing that's called I think it's a podcast that's called PTA Elevate that a lot of people really like. And I bookmarked her, and I meant to watch it, but I haven't gotten around to watching it. But a lot of people like that. And then there's Score Builders also has a thing that they call Base Camp, which is like test preparation thing. And some of them are, I don't know, is there a time limit on PTA 365, or you tell them when you're graduating, Mason?
I don't recall, honestly.
But when you enroll for it, you say what program you're in, what college you're in, what program you're in, and I thought there was a time limit on it. That might not be the case now, but we used to tell people don't sign up for it right away because I think there was a 2-year time limit on it. but that might not be the case now. And also, if you start to, or like if you started it last spring, you probably wouldn't have known any of the questions. Now you'll know some of the questions. So now's a good time to start doing PTA 365. But that's a good resource. But the other thing too is just test taking. A lot of people have a lot of anxiety around test taking. Darren raises his hand. And now's the time to start working on that. So taking practice exams is a good way to kind of train your nervous system to get used to what it feels like to take tests. Because you have to do it. And everybody does it. You can do it. You can do it too. But just that practice taking tests, it's a skill just like anything that needs to be practiced. And so the more you do it and the more comfortable you get with it, the better off you are. Because if you're just so anxious about test taking that the idea of taking the board exam is, keeping you up at night or whatever, that doesn't do you any good. So trying to deal with test anxiety and test taking skills, that sort of thing. So I have some test taking tips that I can share with you that I've gleaned from different sources. And then some ideas for test anxiety. So some people, like, they see the first question and they just get brain freeze. Does that happen to you? Well, I have some
Every exam.
brain freeze ideas. So I will share those ideas with everybody because I think that's good information to know. Because you have to be able to take a test.
I attach electrodes to me and then start turning up every point I miss for Russian.
No wonder.
I'm surprised your brain isn't fried.
Yeah.
Frozen.
That sounds awful.
Yeah.
I get a lot right.
Punished.
That sounds stressful.
Surprised you just don't answer C for everything, Mason.
It happened once. I got up to 46.
But I'm a big fan of positive affirmations for test taking. Because that's the thing is if that's the thing that's a roadblock for you, well then that's something you should work on. At least make it smaller so it's just a speed bump instead of a roadblock. So yeah, I will share some of those resources with you because I think that's important. It's almost like you have to reframe the test instead of as a source of anxiety as like, oh, this is a chance to show off what I've learned. Like Brenda always calls her tests COLs, celebrations of learning. And I don't, but I always call my exams because I'm trying to soften you up. I'm trying to get used to the idea that an exam is not necessarily a bad thing. So I'm using the exposing you to the stressful stimulus in small pieces, and she's using the celebration of learning. So however you want to look at it, but and not that it's not. I mean, of course it's stressful to take your board exam, but you should work on breaking through that stress and training your nervous system to handle a certain amount of stress. Because our nervous systems are actually built to handle that.
All right. I was looking at this PTA 365 and I look up and all I see is this tail.
All I see is a tail. So yeah, PTA 365 and Score Builders Basecamp and Score Builders you can get a book, and like you can buy the book, and usually we'll have the whole class will put in a group order and you get some kind of discount or something for the Score Builders book. But
I was gonna say my my PTA, he's a new, like 2 years, new grad, I would still say. Um, he was really pushing score builders. He's like, he goes, I think everybody in his program did score builders, and I think he
Hmm.
said everybody, but I think one person didn't pass their boards the first go around. So he's a big proponent of like get score builders. It'll help you. So,
And we had the people that just graduated in December just took their board exam in January. And most of them use score builders. A couple of them had some really good things to say about Basecamp. Um, and that's like a supplement. I think the score builders book gives you 3 practice exams. And then it gives you a bunch of material in the book, a little bit of a structure of how to follow it. Basecamp, I think, gives you more structure. Like it says this week study this, so it kind of gives you more structure. If that's something that you want. The Pete, which is the one that you'll get 2 of, and we'll give you access to 2 of those. You can also buy additional Petes, and I used Score Builders and the Pete when I was taking mine, and the Pete is put out by FSBPT, so they have a lot of statistics about it. And if you can pass a Pete exam at 80% or above, then you'll pass the board exam. So that's a good way to taking one of your practice exams early, to point out what areas you need to study. That's a good idea. And then taking the Pete when you're getting close to when you like Brenda has it like a recommended timeline. I think it's 3 weeks before you take the exam or something like that. And if you pass the Pete at 80% or above, then you know that you have a good chance of passing the board exam. So, but if you don't pass the Pete, you should study more. And you should study the areas that it shows up that you're weak in. So that's that's really the book. Me, I like to make charts and spreadsheets and statistical analysis of stuff. So every practice exam I took, I analyzed every question that I missed. Like, did I miss it because I just didn't know the information, because I didn't know the definition of apraxia? Or did I miss it because I read the question wrong, or did I miss it for some other reason? So I, analyzed that, and then I went back. If I missed it because I just didn't know the information, I went back to the original source of the information, like went back to the neuro book or to the O'Sullivan book or whatever book I went back to, and studied that information and then went back to that. So um, I used O'Sullivan a lot, and that's like a primary source for every PT and PTA program out there. Are you guys using O'Sullivan this quarter?
Yes.
Big Red? Yeah. Also, it's good for like killing spiders. I don't know.
the thing is heavy.
Beefy.
It weighs a ton. Yeah, I don't kill spiders. I just take them outside.
And then smash them.
No.
Give
Well,
them last
sometimes
taste
I
of
take
hope.
them for a walk. A few blocks up, one of the neighbors has this big hedge, and
A
I'll
walk?
put them in the hedge. I figure that's a good place for spiders to live. Who am I to say that a
Neighbor's
spider's
yard.
not allowed to live? I found a nice wolf spider and put it in the basement. I'm like, I bet there's some bugs down there. Just eat those guys.
Stronger willed than I.
I didn't like do it with my hands. I caught it in a cup, took it down there. But yeah, taking the practice exams, and the PTA 365 is a really good resource. Also, sometimes, especially about where you are midway through the program, on PTA 365, you see one of those questions, you go, wow, we haven't gone over this yet at all. And that's okay.
Today's
It's just
question is actually
Can you
about gait.
stop that?
Was it the transfemoral one, Mason?
Transfemoral with the heel
The
swing.
whip heel.
Oh,
heel whip,
sure,
yeah.
because you haven't talked
Yeah.
about amputations yet. You'll do that next quarter.
Well, I mean, I just got the question. I answered it correctly, so I was like, "All right." I mean, it's the only answer that made sense to me. So,
Mhm. It's good. So you have good instincts.
yeah.
I love doing
That's
gait
great.
analysis with amputations with prosthetics and stuff. That's really fun. It's very detailed.
I
And
did want to
everybody's a
take a
little bit different.
I was gonna say I wanted to take a picture for you guys. I did see a patient today with that knee crutch.
Oh yeah,
I was
that's
like, I'm like,
cool.
oh, I'm like, I bet everybody would love to see this. I can't take a photo of that guy and send it to
Darn
everybody.
it.
But I was very impressed with how well he could move with it. I would feel almost a little unsteady and unbalanced with it, but he moved pretty smooth, and uh,
That's awesome.
yeah.
But so yeah, you'll see some questions on there that you haven't gotten to yet in the curriculum, and you'll think, wow. But you should be able to answer all the pathology questions pretty well, and a lot of the other ones. So, now's a good time to start with PTA 365.
Oh, well, no, thank you for letting me know about this. This is great. I would love to get a daily question that that'll make me think. So
It's like a daily wake-up call.
exactly. Yeah.
That's good. But it's I don't know, I think nobody puts more pressure on the students than they do on themselves. I think you guys all put a lot of pressure on yourselves. And if I could change that somehow, I would. So I'm just I guess that my biggest thing is a stressed brain doesn't learn well. And so anything you can do to help alleviate stress is going to make it easier for you to absorb and learn things.
Nobody sells me those drugs.
Yeah, totally.
I was thinking more like, you know, relaxation and exercise.
Maybe those too.
The good kind of drugs, yeah. Um, but yeah. But the thing is though, sometimes it does take I've definitely had students who needed to get on an anti-anxiety medication. So sometimes it does take that. But I'm not recommending that. It's outside the scope of my practice. The whatever I bake and knit and exercise. Those are my stress relief things. And make charts. I love to make charts. Makes me happy. So take a look at those charts in the PowerPoint that I posted yesterday, because those are good things to study for the test. If you study those charts, you'll have zero issues. I
And Loretta
promise.
making us weed brownies.
What's that?
And Loretta baking weed brownies for everybody up north.
Weed
Be
brownies.
chill.
Yeah, no, didn't bake you. Did you have those little date bars that I made the
I
last time you
did.
guys were in love?
Those were
How
good.
were they?
They were
I didn't
good.
have any.
Right,
Oh,
did
that's
you
a
make
crime.
them date bars?
Yeah. Well, they were like oat date energy
Bottom line is that
bites.
they got treats.
Yes.
Are you telling me Tony's mom didn't make you treats?
Tony's mom did not make us treats.
Oh, I can ask her. I'm sure she'd
I've
love
been
to.
I'm sure she would come forth with
I've
the
been
treats.
pushing Cassie to make us baked goods again.
Oh yeah, Cassie, she has the goods.
She is very skilled. So
Yeah. So I would be pushing Cassie to make me treats too. But I was trying to come up with a healthy treat. So you like grind up oats in the food processor and dates and put a little coconut oil and spread it out in a pan and put chocolate on the top. I mean chocolate, but chocolate's good for you, right? And then cut it up into little bites. That's not too.
Leah, are you taking notes on this?
I'll send you the recipe. So,
Well, awesome.
anyway, I don't want to encourage
Okay.
bad habits.
All right. Well,
All
I am
right.
good. I am going to go have dinner now before I get back to reading and watching
Me
more lecture
too.
videos. So, I will catch you all later. Have a good evening,
Okay.
everybody.
See you
Thank
there.
you
See ya.
for bringing your questions or sending me your questions, Trisha. That was helpful. I'll see you guys later.
All right. Thank
Do you
you.
have a couple of minutes, Loretta, after everybody goes?
Yes, sir.
Okay, perfect.
Sorry, I'm trying to find my. Oh, here it is.
See you guys.
Button. Bye.
Yeah. Okay. I just had a couple of things that I really wanted to share
Oh,
with you.
Let me